Welcome to the GAP MASLD MASH Community Network. I'm Stacie Egan, a nurse practitioner at Ogden Clinic GI in Ogden, Utah, and I'm excited tonight to talk about advances in MASLD MASH therapy. So the first thing we'll talk about is pharmacotherapy. And you can use this QR code to record your attendance for this meeting. So current available treatments for dysmetabolic management of MASLD MASH. It's the same that we've always had for the most part. Weight loss, lifestyle, diet, physical activity. I recommend Mediterranean diet for my patients with 150 minutes of physical activity a week. I recommend that they have a partner in their exercise just so they have some accountability. I do recommend that they do some weight-bearing exercise because that's helpful. We can also use weight loss medications. Bariatric surgery is recommended. And now we have available GLP-1 receptor agonists for control of obesity and MASH. We do want to reduce cardiovascular risk by treating type 2 diabetes, hyperglycemia, hypertension, and dyslipidemia. We know that MASLD MASH are related to metabolic syndrome, so we always need to address the underlying issues that can make this worse. There are some liver-directed treatments, vitamin E, except in diabetics, pioglitazone, and then our new medication, Resmetirom. So GLP receptor agonists are pretty amazing drugs. They are injectable drugs. You can take some oral as well, but the injectable drug stimulates glucose-dependent insulin secretion, suppresses glucagon, delays gastric emptying, and directly acts on the hypothalamus to promote satiety and reduce energy intake. When you talk to patients that are taking these drugs, a lot of them say that they shut off what they'll say is food noise. Just helps them so they don't feel hungry all the time. It helps them feel satisfied, and it ends up helping them lose weight. So these GLP-1 receptor agonists are analogs of the gut-derived incretin hormone, glucagon-like peptide. They lower blood glucose and cause weight loss. So these can also help with type 2 diabetes, which is a big reason why people end up with metabolic associated steatohepatitis. And we know that weight loss helps with this as well. We've always recommended that our patients lose 7 to 10% of weight, which can be really challenging. And these medications can help with that. The role of a GLP-1 receptor agonist in hepatology practices, in a study of over 72 weeks, 2.4 milligrams once weekly successfully met both primary histological endpoints of MASH resolution without worsening fibrosis and significant improvement in liver fibrosis without worsening MASH. So this is a great drug for a patient with metabolic associated steatohepatitis. You should consider GLP-1 for overweight MASLD patients with a higher priority given to those with MASH or fibrosis. This is not a drug that would be for your patients who have lean MASH. So how does this affect our GI practice? If you are prescribing these drugs and you're going to do any sort of GI procedure like an endoscopy, colonoscopy, we usually have them discontinue this drug, or in my clinic, we tell them that they can do a 48-hour liquid diet before the procedure, but it can cause them to have some food retention. It puts them at a higher risk with anesthesia. So I always talk to patients about GLP-1 receptor agonists and any sort of GI procedures. We want to stop these medications. Vitamin E has been recommended for non-diabetic MASH patients without cirrhosis. In the PIVENS trial, which was a landmark study that showed vitamin E improved liver histology in non-diabetic adults, they found that approximately 43% of these patients showed histological improvements. Not all patients respond. You can't use this in hypertensive or diabetic patients. The 2023 AASLD guidelines suggest vitamin E may improve NASH in non-diabetic individuals, but the 2024 EASL, EASD, and EASO guidelines do not recommend it as a MASH therapy due to limited efficacy on fibrosis and the potential risks. So if you are going to recommend vitamin E at that 800 international units a day, you do have to talk to them about bleeding, prostate cancer concerns, and we do have to make sure that we're choosing the right patients for any of these drugs. Pioglitazone is also something that you can use. This is for MASH patients with type 2 diabetes, 30 to 45 milligrams a day. The PIVOTS trial showed that there was no benefit of pioglitazone over placebo for histologic features of MASH. However, this can help with cardiovascular risk. There are some side effects, including weight gain, edema, bone fractures, especially in women, and a possible association with an increased risk of bladder cancer. So again, careful patient selection and monitoring if you're going to choose this drug. Last year, a new drug was FDA approved in conjunction with diet and exercise for the treatment of adults with non-cirrhotic, non-alcoholic steatohepatitis with moderate to advanced liver fibrosis. So that's F2, F3 liver fibrosis. This drug is called Resmetirom or Resdifra. It's a thyroid hormone receptor beta agonist, and it selectively binds to and activates the thyroid hormone receptor beta in the liver. So it's very liver specific. So how does this work? So when you're thinking about resmetirom, you do have to think about the relationship between the thyroid and the liver, and this will help you appreciate how this works. So thyroid hormone receptor beta helps the liver with lipid metabolism. So it breaks down excess fat, which is helpful. It increases mitochondrial biogenesis and helps remove aging and damaged mitochondria. So helps the liver work better. We know the mitochondria are the powerhouses of the cell. And so it helps the liver function more like a normal liver. And this is how it works. It's liver directed. So we all know about thyroid hormone receptor alpha. Thyroid hormone receptor beta is a lot more selective for the liver, and it works really well in helping with these changes. So in the Maestro-NASH study, which is an ongoing phase 3 randomized controlled trial of resmetirom in NASH with liver fibrosis, patients with biopsy-confirmed NASH and a fibrosis stage of F1B, F2, or F3 were randomly assigned in a 1-to-1-to-1 ratio to receive once daily oral resmetirom, 80 milligrams, 100 milligrams, or placebo. There were two pretty lofty primary endpoints at week 52. Number one was NASH resolution, including a reduction in the NAFLD activity score by greater than or equal to 2 points with no worsening of fibrosis, and an improvement reduction in fibrosis by at least one stage with no worsening in steatosis. So you can see that these are pretty lofty goals, actual mass resolution and a reversal of fibrosis by at least one stage. So this was a great study and really did look for some very specific primary endpoints. The Maestro-NASH phase 3 safety did show that diarrhea and nausea were more frequent with resmetirom than with placebo. But you can see the incidence of serious adverse events across all groups were similar, including placebo. One thing to note about the diarrhea and nausea, these usually start early in treatment in about 1 week with the 100 milligram dose and up to 3 weeks after starting the 80 milligram dose. They do seem to be self-limiting. They last 3 to 4 weeks and then they seem to get better in most patients. This is something that I always educate my patients about. It makes them more likely to stay on the drug if they know that their side effects are normal and that they usually get better. The diarrhea was seen in patients who already had diarrhea, so worsening diarrhea. This is just something that we need to educate our patients about as APPs. It will help your patient be more compliant. I have not had any patient discontinue therapy because of this. And I think that's partially because I do a really good job of educating them, so they're planning on it. So that would be a great idea for any of you planning to prescribe. When we look at these phase 3 primary endpoints, like we said, NASH resolution with no worsening of fibrosis and fibrosis improvement by greater than or equal to 1 stage with no worsening in steatosis. You can see that both the 80 milligram and the 100 milligrams were superior to placebo with respect to NASH resolution and improvement of resolution and improvement in liver fibrosis. So when you look at the 80 milligrams, 25.9% versus 9.7% in placebo, and 29.9% of the 100 milligram versus 9.7% placebo in the NASH resolution, and our improvement in the in the fibrosis without worsening of the NAFLD activity score is also significant. In my clinic, I have seen that this drug really does improve when you do FibroScan at 52 weeks, like I've done. Most of my patients have met these primary endpoints, and they're very happy with treatment. So when you're thinking about using resmetirom for these patients, the ideal patients are patients who are adult with non-cirrhotic MASH. So this has not been approved in cirrhosis, especially not decompensated cirrhosis. So these are patients with moderate to advanced liver fibrosis stages F2, F3. I usually measure this with FibroScan, though there are some other tests you can do, like MRE, or you could get a biopsy. And it's only improved in conjunction with diet and exercise. So I always tell my patients, we'll start the medication, but we're still going to make those changes to your lifestyle that need to be made so you can have the best results. So that would be diet, exercise, avoidance of alcohol. When you are managing MASH with resmetirom, there are some drug-drug interactions. If they're on donepezil or cyclosporin, drugs like that, this is contraindicated. If they're on something like Plavix, we just need to reduce resmetirom to by 20 milligrams. So if you were going to prescribe 100 milligrams, now you prescribe 80. If you were going to prescribe 80 milligrams, now you prescribe 60. You can have increased exposure due to resmetirom if you're on pioglitazone or any of the other medications listed in this box. The montelukast is one of them that your patients may be on. That's pretty common. With statins, you need to think that with pravastatin and atorvastatin, the maximum dose allowed is 40 milligrams. So you would want to decrease the dose of the statin before you start resmetirom. You would still keep them on the 100 milligrams for 100 kilograms or more, 80 milligrams for 100 kilograms or less, but you would make sure their statin dosing is correct. So pravastatin and atorvastatin, that's 40 milligrams. Simvastatin, rosuvastatin, that's 20 milligrams. So just make sure that you're making these adjustments when you're prescribing or avoiding drug totally if they're on the strong 2C8 and or P1B1 3 inhibitors. Practical considerations, there is an ongoing trial, MAESTRO-NASH trial, that is going to hopefully at some point give us the duration of treatment and monitoring. Likely we will need to restage fibrosis, steatosis with non-invasive testing. I do this with a FibroScan at 52 weeks like they did at the trial. I do not usually get a biopsy like they did during the trial, but whatever I do initially is what I will do at 52 weeks. I also repeat labs, CBC, CMP. I keep track of their thyroid hormone and their fasting lipids. Expert panels are currently working on better guidelines for this, and we should have them at some point. But for now, I am keeping my patients on the drug once I start it and just monitoring with labs and repeat non-invasive testing. Like I said, whatever I started as my non-invasive test, I continue that. Questions do remain. Will this be covered by insurance companies? So far, I've had good response with insurance companies. About 87% of commercial insurance companies are covering this. There's also coverage for Medicaid, Medicare, and there is a patient assistant program that's available for your patients. We do need to do periodic staging and lab tests. Hopefully, we'll have some better guidance on that. We will need duration of treatment recommendations. So once the patients have reversal of fibrosis and steatosis, do we stop the drug? Do we keep them on it? We're not sure yet, but I am keeping my patients on the drug because there aren't those guidelines. There are multiple agents in clinical trials, so I'm guessing that we're going to have a lot of different pharmaceutical therapies for MASH with fibrosis, which is really exciting for any of us in GI hepatology. If you would like some more disease state education, you can visit the GAP MASLD MASH Community Network for additional disease state education and a Resmetirom webcast. So you can just scan that QR code if you're interested. And then please scan this QR code to give us some feedback. We'd like a short survey to share your thoughts on today's presentation. Your insights always help us continue to improve our presentations. We're open for questions and answers at this time. So if anyone has questions, I'm happy to answer them now.